Good afternoon, dear professors and colleagues. I'm so happy to have you with us today. Now we are going to start the session about everything about the challenge in the management of HER2 positive breast cancer. It's my honor to invite the great professor, Dr. Ala Adil, professor of clinical oncology, Alexandria University. He will talk about de-escalation of adjuvant and neoadjuvant treatment in HER2 positive breast cancer.
بسم الله الرحمن الرحيم. Thank you Mrs. Chairman. وبأشكر دكتورة أماني وكل القائمين على الأورجنايزنج كوميتي لأن ده شرف ليا أن أنا أكون في المؤتمر الناجح دايما مؤتمر بهية ده. This is the title that was given to me by Professor Amani Hilal, which is neoadjuvant and adjuvant therapy in early HER2 positive breast cancer, and we will talk only about de-escalation, not escalation. I guess everybody knows that HER2 positive breast cancer constitutes about 20% of all breast cancer subtypes. It's a very unique subtype. Needs targeted therapy, has different types of risk, low, intermediate, and high. And already through the years, we have identified the time to metastatic disease or the relative survival is definitely not only related to the HER2 status, but also to the ER status. So, and the worst would be HER2 positive ER negative tumors, as you can see from the slide. As I mentioned, it's about 20% of invasive breast cancer. It's a family of 4 transmembrane tyrosine kinase receptors, which different type and pattern of spread and response to different types of treatment and. I guess these are very basic stuff that everybody in the room should know about. Early data, when we were using only trastuzumab or Herceptin, we identified 3 main factors that would determine the outcome of a patient with HER2 positive disease, and that was the primary tumor size, the lymph nodal status, and the HER2 status. As you can see from the right-hand side, these are the only 3 significant factors: the tumor size and the lymph nodal status and the HER2 status. Usually negative is worse than positive HER2 positive. Most importantly, as per the title given to me by Professor Amani, is to assess the risk of a certain patient with HER2. Is this patient a low risk? Is this patient a high risk? How to apply a certain treatment strategy for every patient, not only in terms of efficacy, but also in terms of toxicity. And this is very important. It's not only like one size fits all. No, HER2 positive patients are really different. What do we try to do? أنا بص حضرتك أنا كفاية صور كده خلاص كده تمام. شكر جدا. Okay. There are different strategies to escalate the tumor, whether to decrease the treatment we're giving, use hormonal therapy versus chemotherapy, use less chemotherapy, 1 anti-HER2 therapy versus 2 anti-HER2 therapies, and last but not least is the duration of the treatment that we apply. And I'll try to discuss these points separately. Now, very early data about the de-escalation trial, the APT trial. This is a very well-known trial, but most importantly, you have to concentrate on the eligibility criteria of this trial. As you can see on the left-hand side, these are HER2 positive disease, either ER positive or ER negative, node negative disease. And this is the most important part. The eligibility criteria of this trial named tumors less or equal to 3 centimeters. But to tell you the truth, don't really try this APT for tumors more than 2 centimeters. Why is that? Because the population of the patient included in this trial, only 10% of the patients were more than 2 centimeters. So we cannot really judge the tumors, the larger tumor of 2 to 3 centimeters. A tumor with 2.5 or 3 centimeters HER2 positive disease is a big tumor. So my advice, if you take it, it's already in the inclusion criteria, but only 10% of the patients did have tumors more than 2 centimeters, okay? And the protocol is very simple. You apply 1 single chemotherapy agent and trastuzumab. And the outcome was excellent. As you can see, the APT 7-year follow-up was showing a 3-year and 5-year and 7-year excellent, above 90s event-free survival. And this is very assuring that with very low-risk patients, early-stage disease, node negative, small tumors, you can use this regimen for those patients, the APT regimen. I guess we're done with that. One most important thing, which I'd like my junior colleagues to know about, is the use of anthracyclines in the treatment of HER2 positive disease. We do not recommend the use of anthracycline in HER2 positive disease. Okay, not anymore. اسف هتكلم بالعربي بعد اذن التشيرمان، مش عشان القرار هيتاخر هنبتدي 4 اي سي لحد ما القرار يجي، مفيش حاجه اسمها كده خالص. ابتدي تاكسو الكربو. You're adding toxicity with no benefit as you will see. لو الانثراcycline will add any benefit to the patients with HER2 positive disease, please use it, but it doesn't. Okay? Right. And why is that? Early on, you remember in 2005 when we had the approval of the adjuvant therapy for HER2, we had 4 main trials. One of them, which is the very famous 006 by Dennis Lehman, that was the only trial that had an arm that did not include anthracycline. All the other 3 trials did not dare to do that. They have to include anthracycline in their treatment arms. Apart from Dennis Lehman, he was very courageous, and he did not put anthracycline. And there was one arm that was only Taxol Carbo plus or minus Herceptin. And the results was as good as using anthracycline, and more importantly, far significantly less toxicity, mainly the cardiac toxicity. It was less than half, which is extremely important because you don't want your patient to suffer from cardiac toxicity later on. Okay, this is Dennis Lehman, and in his, this is a very brilliant guy from UCLA, by the way, and his analysis showed the toxicity profile of patients receiving anthracycline with anti-HER2 therapy, namely trastuzumab, and the trial included 3,000 patients. And aside of this trial, there was 1,500 patients with HER2 negative disease. And he looked very carefully in those patients. And he found out that only the patients who might need anthracycline, being HER2 positive, are the ones with topo2 abnormality. And that, as per his calculations, does not exceed more than 8% of the total breast population. So I don't think this is enough to apply anthracycline and increase toxicity for those patients with anti-HER2 therapy. This is an important lesson. So these are the early data. What are the most important real data? The TRAIN2 trial. The TRAIN2 trial, again, is anthracycline versus no anthracycline. And you can see that in terms of event-free survival, there's no difference whatsoever. And the PCR rate on the right-hand side, there's no difference whatsoever by adding anthracycline. But most importantly is on the right-hand side is the decrease in the cardiac toxicity. There is a significant decrease in the cardiac toxicity by omission of anthracycline on HER2 positive patients receiving anti-HER2 therapy. I hope that will convince you that there's no point to do this. And this is the cardiac toxicity. As you can see from the figures, it's more than double by the use of anthracycline. Okay? For all of the above, the data provide reassurance that anthracycline can be omitted from patients with early HER2 positive breast cancer. And this is actually the very strong statement that came from Sarah Horowitz, a very known breast oncologist. It's becoming hard to justify routine use of anthracycline-based therapy for HER2 positive disease. I guess this is very convincing and very strong statement from a very well-known breast oncologist in the USA. NCCN would already remove anthracycline from the basic regimens for HER2 positive disease early stage. Now we'll jump to the second point of the escalation, which is the duration. Whether should we still stick to the 1-year adjuvant therapy of anti-HER2 therapy, or can we go for a shorter period, which is either 9 weeks or 6 months? We have 5 major trials. The first 3 trials are talking about 9 weeks versus, the first 2, 9 weeks versus 1 year, and the lower one are 6 months versus 12 months. Okay? All the 4 upper trials are negative. There was only one trial that was positive, which is the Persephone. This is a French trial, by the way, the very lower trial. And what did this say as a conclusion? That 6 months of adjuvant Herceptin is non-inferior. It was a non-inferiority trial, by the way. Is not inferior to 1 year. However, there are lots of criticism to this trial, as you can see. Okay, this is the trial, by the way. The design of the trial is 6 months versus 1 year. No big deal. Again, you can see that the disease-free survival, as per the researchers of this trial, is more or less the same. And the overall survival is the same. However, and this is the conclusion, is they mentioned it's non-inferior. However, that was criticized very much to the extent it did not go into any guidelines. There's no guidelines that would put 6 months anti-HER2 therapy in the adjuvant setting. Still, all guidelines would call for 1 year, 12 months. Okay? And why is that? Because these are very clever remarks from Martine Picard. She criticized the trial eligibility criteria. Most of the patients in this trial were low-risk patients, which is not the case in our daily clinical practice. Okay? ER positive was the majority of the patients, not ER negative. So you cannot judge and base your practice on something like that. You have to have a real stuff of a patients that really represent the patients we see in the clinic. So as for now, unless you have a financial problem for sure, and you cannot give 1 year of Herceptin, this is another issue, but it's not a scientific issue. For the science, it's 1 year, the standard of care, anti-HER2 therapy for those patients, whether being Herceptin or Herceptin Perjeta as per the recent data. The other one factor, which I'm glad that Professor Nadia Mukhtar is with us, she's the expert, is the look, as we already know in the triple negative disease, in the TILs, tumor infiltrating lymphocyte. It has a big meaning in patients with HER2 as in patients with triple negative. As you can see, the 2 dotted lines represent the PSR with high TILs and with low TILs. And in that other slide, even the patients with residual disease, the patients almost always with high TILs do better. Either they receive complete pathological response or no complete pathological response. So this is something that we might ask from our dear pathologists to look at, as we sometimes do in the triple negative disease, that might help us in augmenting the treatment or decreasing the treatment or de-escalation, as we are talking today. This is collectively the summary of what I was just mentioning in the previous slides. So, how do we do better in terms of de-escalation? One of them is to look for biomarkers that would help us. And the second one, which is already in our hands, it's the so-called open eye type of treatment. You have to assess the response and accordingly tailor your treatment to certain patients. Okay? This is the ADAPT trial. The ADAPT trial is a very complicated trial. Okay? It's an umbrella of trials that would give patients a certain type of treatment, evaluate the response, and those patients, according to their type of response, would go either A or B or C. This is a very dynamic way of trial. Okay? As you can see, it's an umbrella of trials, included a good number of patients, nearly 5,000 patients. And I just never go to the design of this trial unless you are one of the principal investigators in. This is the design of the trial. How complicated it is. I don't know if in the future we'll follow such a trial and this type of trials or not, but at least this is a very good way to treat our patients and tailor the treatment as we almost always do or try to do. Okay? Another one in terms of de-escalation is the so-called ATTEMPT trial. The ATTEMPT trial is designed to determine the efficacy of adjuvant TDM1 and determine safety in patients with early stage 1 HER2 positive breast cancer. Again, this is the trial design, TDM1 versus the regular or conventional paclitaxel and continuous trastuzumab. And actually, the conclusion of the trial that it might give you an alternative if any patient will not tolerate the APT trial, the APT regimen. So at least you have something, more weapon. We'd like in oncology to have more than one way to manage our patients. If a patient, Taxol, Herceptin is not suitable, you can do a TDM1. It's not inferior. This is one way to de-escalate. And last but not least, this is a real open eye trial, the Fergain trial. This is a response guided using PET-CT. Okay? It has 2 arms. The group A arm, which is the HER2 blockade plus chemotherapy. And the group B is the real de-escalation arm, which is only anti-HER2 therapy, pertuzumab and trastuzumab. Actually, this is not a standard of care. You remember one of the first neoadjuvant trials, we had trastuzumab and lapatinib, and one arm plus chemotherapy for sure did not include any chemotherapy. Only 2 anti-HER2 therapies. And mind you, the PCR in those patients was 17%. This is quite high. not using chemotherapy, and not even using in the neoadjuvant setting any hormonal therapy, this would ring a bell that not every single patient would need the standard treatment. It's another way to look into the de-escalation strategy more. Those patients are assessed after 2 cycles by PET-CT. Patients were considered PET responders if the scan showed a reduction in the breast lesions of at least 40% from baseline. So you give 2 cycles, you do a PET-CT, and you name those patients or label those patients as responders or non-responders. Okay? Those responders are going in one way and they continue the same. The non-responders would go to the other arm, which includes chemotherapy plus anti-HER2 therapy. And the PCR rate was quite convincing in the experimental arm, about 40%. The 3-year invasive disease-free survival was quite convincing. And again, efficacy, secondary endpoint in terms of distant disease-free survival, event-free survival, overall survival was very convincing. And now we're talking about omitting chemotherapy in this trial arm. These are the safety, actually more or less the same. Most importantly is the lower part of that slide. What does that trial tell us? That at least 1 in 3, 30% of the patients with HER2 positive early breast cancer who can safely omit chemotherapy and thereby significantly reduce toxicity. Just imagine that certain group of patients are not receiving chemotherapy. For the patients, it's nice. It's so nice. Most of the patients are not against anti-HER2 therapy, but they're definitely against chemotherapy. And I guess everybody knows that from our clinic on daily basis. The one very major advantage now is like we use in the ER positive disease, we use the Oncotype DX, is the HER2DX. HER2DX, I'm sorry. This is another oncogenic type of testing to judge the risk category of this HER2 patient and to escalate or de-escalate the type of treatment. It's already been there and it has extensive correlative analysis from the PERILISA trial. The PERILISA trial actually was aimed to evaluate the efficacy of a de-escalated chemotherapy-free neoadjuvant regimen they were applying in the triple positive, ER positive, HER2 positive breast cancer patient. They were using hormonal therapy plus dual anti-HER2 therapy. And they used the Ki-67 to measure the efficacy of the treatment. No chemotherapy whatsoever. Okay? And it did predict the response following neoadjuvant letrozole in combination with dual HER2 blockade with trastuzumab and pertuzumab in early stage HER2 positive. Another way, the first one was using a PET-CT, the other one was using the Ki-67 in triple positive disease. Okay? The first one did not have to be for the patient triple positive disease. Okay, and this is actually the ESMO clarification and consolidation of this fact. And it mentioned very clearly that the HER2DX assay is highly reproducible and robust for the quantification of recurrence risk and the PCR likelihood. The last part of my trial, and I'm متأسف إذا كنت طولت على حضرتك, just came 2 weeks ago اللي كانوا منكم في الإزمو, and that was a practice-changing trial presented in the presidential session of the ESMO. And this is the Destiny 11. Okay, there was 2 very important trials. One of them related to the de-escalation. That's why I'm presenting it, the Destiny 11. And all the Destiny trials are for the ADC, the Enhertu. Okay? Now, what's that trial telling us? That you can use less chemotherapy by the addition of DXD and THP versus the standard of care, the full lot of chemotherapy plus 2 anti-HER2 therapies. It's as simple as that. So in the investigational arm, we were using less chemotherapy, using DXD as an anti-HER2 therapy that contains a chemo component for sure, and dual blockade versus the conventional arm. And the results were all in favor of the de-escalated line of treatment. As you can see in terms of PCR, you found 11% difference. And that was consistent in ER positive and ER negative, 9% and 16% difference. Look at the subgroup analysis, what was very convincing in any subgroup of the patients you choose in favor of the de-escalated arm using DXD and less chemotherapy. Again, the residual cancer burden was in favor of the DXd in ER positive and ER negative tumors. Event-free survival was significantly about 44% as per the hazard ratio, 0.56 in favor of the de-escalated R. This is the summary, efficacy summary, event-free survival, and this again, the safety was quite convincing. It was not more toxic. This is something, for us, it would definitely be more toxic because financial issue to apply DXd. But anyway, at least we have to be prepared لحد ما الاسعار تنزل، يعني زي ما كنا زمان بنستخدم التاكسينز والحاجات دي كانت غاليه علينا، لكن دلوقتي بقت روتين. اتصور ان ده هيحصل ان شاء الله باذن الله. لكن at least for the time being there is a financial toxicity of that. But most importantly, I didn't put the slide. The trial design, I already put 2 arms. There was a third arm. The third arm was using only DXd and was stopped. Why? Because the PCR rate was only 40%. It's very good, but it's less than the other 2 arms, 56 and 49. So 40%, the trial, that this arm was stopped. These are the conclusions of this trial. The Destiny 11 results support DXd-THP as a more effective and less toxic neoadjuvant treatment compared to the conventional chemo anti-HER2 therapy for a subgroup of patients with HER2 positive disease. Thank you so much.
Dr. Ale, thank you very much. Actually, you tackle a very important issue we are facing in the treatment of patients with HER2 positive disease. The availability of treatment and the long-term toxicity is challenging in this patient. But now, after this very excellent presentation, we need message to take home. I need for the early breast cancer patients with HER2 positive, if it is low risk, what we should give. If it is high risk, what we should give. This is the point only.
Well, my first one, please, if you are convinced with what I said and the data I presented, avoid anthracycline. This is number 1. In HER2 positive patient, really, there's no need. I'm مش عايز اتكلم كلام زي مش عايز اقول كرايم، انما التوكسيستي اللي الناس العواجيز اللي زي بيشوفوها مع الديوال يوز اوف انترسايكلين والانتي هير2 ثيرابي مش كويس. يعني ما فيش اي شطاره في ان انا العيانه بتاعتي بقى تبقى كاردياك بعد فتره من الزمن علشان انا اصريت ان انا ادي لها انترسايكلين. There's no definite improvement. ده اول نقطه يا دكتور. الحاجه الثانيه، we have the right in the triple positive disease in old patients, frail patients that will really not tolerate the full chemo anti-HER2 therapy, we might omit the chemotherapy in those patients and use hormonal therapy plus anti-HER2 therapy in certain patients, and it does the job very well. Okay, and more importantly, وده للاسف ما بيحصلش للاسف شديد. Please, when you do neoadjuvant therapy, follow your patient on every cycle. عشان خاطري العيانين اللي بيقعدوا ياخدوا 5-6 جلسات وبعدين في الاخر نشوفهم مش ريسبوندرز، دي حاجه مؤسفه جدا. ده مش neoadjuvant therapy خالص. Neoadjuvant is that you give treatment, it's an open eye type of treatment, and evaluate the response. Evaluate the response clinically, evaluated by an ultrasound, by a PET CT لو عندك فلوس. هتعرف تعمل KI67 مره او 2، يا ريت لو العيانه وافقتك انها تعمل بايوبسي ثانيه. But you might spare some patients the toxicity not only of the anthracyclines as I mentioned but also for chemotherapy. فارجو ان انا اكون جاوبت سؤال حضرتك كده.
Thank you very much, Professor. I know everyone has question for Professor Dr. Ale, but already we are beyond the schedule of time. We'll shift for the next presentation. Then at the end of this presentation, we'll have the discussion.
The second lecture by the title Sequencing of Treatment in Advanced HER2 Positive Breast Cancer. It will be presented by Professor Azza Darwish, Professor of Medical Oncology, NCI, Cairo University. The floor is yours.
It's very difficult to talk after Dr. Ala and Zil, but I will try. My presentation is Sequencing of Treatment in Advanced HER2 Positive Breast Cancer. Treatment of advanced HER2 positive breast cancer has witnessed a marked evolution in the past decade, We have now multiple and new treatment and HER2 treatment. And I would like to review rapidly the key trials that shaped the current guidelines for HER2 positive advanced breast cancer in order to compare the magnitude of benefit that we see before with the first treatment and the magnitude of benefit we are seeing now with the newer agents. For sure, I will start with the Cleopatra trial. It was the first trial that shaped the current guideline for advanced HER2 positive breast cancer. As you know, in this trial, addition of pertuzumab to trastuzumab and docetaxel significantly improved the progression-free survival and overall survival. The progression-free survival improved from 12 months to 18 months, and the risk of death reduced by 32%. Another important trial is the PIROSE study. This study is a large phase 3 randomized study that randomized patients with HER2 positive advanced breast cancer to receive trastuzumab, pertuzumab, plus one of the three taxanes, Taxol, docetaxel, or nab-paclitaxel. The trial found no difference in the progression-free survival or overall survival among the three taxanes. Definitely, with fewer toxicities and better tolerability with paclitaxel. And since this trial, trastuzumab, pertuzumab, and paclitaxel became the standard of care as a first-line treatment for HER2 positive advanced breast cancer in all the guidelines. And just remember, the PFS here is just 18 months. Moving to the second line. We have the EMILIA study. EMILIA study recruited patients with HER2 positive advanced breast cancer who progressed on trastuzumab, either in the first line setting or in the adjuvant setting. The patients were randomized to receive lapatinib, capecitabine, which was the standard of care at the time, or Kadcyla. T-DM1 significantly improved the progression-free survival and the overall survival. So, based on this study, T-DM1 was approved as the second-line treatment of benefit in treatment of HER2 positive advanced breast cancer, and the PFS is just 6 months. Another pivotal study in the second-line setting is the DESTINY-03 trial. This trial enrolled patients similar to patients in the EMILIA study, patients who progressed on trastuzumab and taxanes, but the difference thing is that in the DESTINY-03 study, most of the patients received prior pertuzumab. Okay? The patients were randomized to receive T-DM1, which was the standard of care at the time, or T-DXd. T-DXd outperformed T-DM1 with a marked separation of the two curves as regards the progression-free survival. As you see, the progression-free survival improved from just 6 months with T-DM1 to 28 months with T-DXd. Also, the overall survival was significantly improved. The important thing of the DESTINY-03 trial, it was the first phase 3 trial to compare two ADC together, T-DXd versus T-DM1. And as you see, T-DXd outperformed markedly T-DM1. And that's why this trial reshaped the guidelines in the second-line setting, and T-DXd now replaced T-DM1 as the second-line treatment for HER2 positive advanced breast cancer. Then moving to the third-line setting. We have multiple options in the third-line setting. The first option is T-DM1, and it's tested in the THERESTA trial. This trial enrolled patients with advanced HER2 positive breast cancer who progressed on trastuzumab, taxanes, T-DM1, lapatinib, trastuzumab, pertuzumab, and lapatinib. The patients were randomized to receive trastuzumab plus chemotherapy, which is the standard third-line treatment, or Kadcyla. Kadcyla improved the progression-free survival and the overall survival significantly. So, T-DM1 was approved as a third-line treatment for HER2 positive advanced breast cancer after this trial. Another important trial in the third-line setting is the DESTINY-02 trial. This trial enrolled patients who relapsed on trastuzumab, pertuzumab, and T-DM1, and then they were randomized to receive, again, taxanes plus chemotherapy, the standard of care of the third line, or to receive T-DXd. Again, the important point of this study is the fact that the first phase 3 study to compare the efficacy of T-DXd, or ADC, after ADC. Here, the patient progressed on T-DM1, and then they randomized to receive T-DXd. TDXD significantly improved the progression-free survival and the overall survival as usual. So TDXD is approved based on this study as a third line. It's very important to show that patients on the control arm, most of them received TDXD upon progression, yet the PFS2 with the TDXD arm still markedly improved. Another option in the third line is the tucatinib. Tucatinib was tested in the Her2 study. It's a phase 3 trial enrolling patients, again, who relapsed on trastuzumab, pertuzumab, TDM1, and they were randomized to receive trastuzumab plus capecitabine plus or minus tucatinib. The key feature of this trial, it was the first phase 3 study to enroll patients with active brain metastasis. Actually, 50% of the patients in this study had brain metastasis between stable or active brain metastasis. Tucatinib improved the progression-free survival and overall survival. So another regimen to be approved as a third line in the treatment of HER2-positive advanced breast cancer. So this is the guidelines here. You can give in the third line tucatinib, trastuzumab, and capecitabine with a PFS of 7.8 months. You also can give TDXD or TDM1 if they are not previously prescribed. So the treatment of HER2-positive advanced breast cancer has markedly evolved in the past years, with a median overall survival now exceeding 40 months. And due to the unprecedented result of TDXD in the second and in the third line, TDXD is now tested in the first line setting in the DESTINY-09 trial. Here, patients with HER2-positive advanced breast cancer in the first line setting, they were randomized to receive either the Cleopatra regimen, trastuzumab, pertuzumab, taxanes, or to receive TDXD plus pertuzumab. Amazing result. TDXD plus pertuzumab beats the Cleopatra regimen with progression-free survival 40 months versus 26 months. But till now, this trial doesn't change the current guideline. Still till now, the Cleopatra regimen is the standard first-line setting for patients with HER2-positive advanced breast cancer. The question is, if I have a patient who received anti-HER2 treatment in the first line or the second line and achieved complete radiological response or even stable disease for several years, when to stop the anti-HER2 therapy? We have two analyses, one done in Europe, in the right-hand side, and one done in USA. They are asking this question, can I discontinue anti-HER2 therapy in patients who are long responders? First, I have to know who are the patients who are long responders and how many are these patients. In these two analyses, we found that 25% of the patients with advanced HER2-positive breast cancer, if they receive chemotherapy and anti-HER2 treatment, 25% of them will be progression-free for more than 2 or 3 years. And these patients, if I continue giving them anti-HER2 treatment, most of them will not relapse. So about quarter of the patient, they are exceptional responders. And the question, can I have the evidence to stop the anti-HER2 treatment for this patient in order to minimize the toxicities? We have 2 trials ongoing now. These trials, they enrolled patients who are progression-free for more than 2 or 3 years. In addition, they have circulating tumor DNA negative. So they add testing circulating tumor DNA. If they are negative and they are progression-free for more than 2 or 3 years, they are randomized either to continue the anti-HER2 treatment or to stop the anti-HER2 treatment. So we are waiting for the result of these 2 studies. Then moving to another point, hormonal receptor status and its impact on prognosis and treatment in HER2-positive advanced breast cancer. This is data from the SEER database. It showed that patients with hormone receptor positive, HER2 positive, they have better prognosis compared to patients with hormone receptor negative, HER2 positive. And this has a biological basis. If we look at the molecular subtypes of patients with triple positive breast cancer, actually half of them have luminal A and luminal B. And we know that these tumors are less aggressive and they can be treated with hormonal treatment and anti-HER2 treatment without giving chemotherapy. However, if we look at the patients who are hormone receptor negative, HER2 positive, most of these patients are HER2 enriched. And 9% of them are basal. These tumors are aggressive and they definitely need cytotoxic chemotherapy. So there is a biological basis for why patients with hormone receptor positive, HER2 positive, they have better prognosis. If we look at the cellular basis, actually there is a crosstalk between the estrogen receptor signaling pathway and the HER2 signaling pathway, and also the cross-signaling with the CDK4/6 inhibitors. That's why this is the rationale for why to give hormonal treatment plus anti-HER2 in patients with triple positive. So what is the data that we have now? We have the Patricia study. This study randomized patients with advanced HER2 positive and hormone receptor positive breast cancer who received several lines of anti-HER2 treatment and several lines of chemotherapy, and then they progressed. These patients were randomized to receive either trastuzumab plus single agent chemotherapy or to receive trastuzumab plus endocrine therapy, AI or fulvestrant, plus palbociclib. And interesting thing is that palbociclib and endocrine treatment plus trastuzumab significantly improve the progression-free survival compared to chemotherapy. So in patients with triple positive breast cancer, don't forget this regimen, CDK4/6 inhibitor plus endocrine therapy backbone plus anti-HER2. It's better than chemotherapy plus trastuzumab. This is in patients who failed multiple lines. Another trial is the Her2 study, again testing the same question. Patients who failed multiple lines of anti-HER2 treatment and failed chemotherapy and T-DM1, these patients were randomized to receive trastuzumab plus single-agent chemotherapy or abemaciclib plus endocrine therapy backbone plus the anti-HER2. Again, the same result. CDK4/6 inhibitor plus endocrine treatment significantly improved the progression-free survival compared to cytotoxic chemotherapy plus anti-HER2 treatment, definitely with better tolerability for these patients. Hormonal treatment was also tested in the first-line setting. Patients in the first-line setting who are triple positive, usually we start with induction chemotherapy phase for 6 to 8 months with taxanes, Herceptin, and Perjeta. Patients who are free after this induction treatment, we usually stop the chemotherapy and then we continue the anti-HER2 treatment plus endocrine therapy. In the Patina study, they compared the patient whether to receive the anti-HER2 therapy plus AI or fulvestrant or to add palbociclib as a maintenance treatment after the induction phase. Very interesting study with a marked improvement in the progression-free survival. It improved from 29 months to 44 months just by adding palbociclib in the maintenance phase. So if we consider 44-month progression-free survival with palbociclib and anti-HER2 therapy, in addition to the 6-month interval of the induction therapy, we are talking about more than 4 years progression-free survival. We have never seen this result in advanced HER2 positive breast cancer. I think this trial should lead to a routine use of palbociclib plus hormonal treatment and anti-HER2 therapy as a maintenance for patients with triple positive after they finish the induction treatment. We have other therapies like neratinib, engelumab, and pyratinib. All these lines can be used in the third or later lines. So just to summarize, till now, the first line treatment for advanced HER2 positive breast cancer is taxane, trastuzumab, and pertuzumab. The second line is T-DXd. We can use tucatinib, capecitabine, and trastuzumab in the second line in patients only with active brain metastasis. The third line option is tucatinib, capecitabine, and trastuzumab, T-DM1, or T-DXd if you haven't used it before in the second line setting. In the fourth line and later, we have multiple options, lapatinib, capecitabine, trastuzumab with single agent chemotherapy, or clinical trials. And thank you.
Thank you so much for this comprehensive illustrative talk. And now we will move to the next session. We will delay all the questions. And now we'll present Dr. Ahmed Magdi from NCI. He will talk about other target HER2 in locally advanced breast cancer. The floor is yours.
So good evening, everyone. Thank you for the invitation. I would like to say that I'm proud to have been one of the team in Baheya under the leadership of Dr. Amani Hilal. وبحب أشكر دكتور أماني هلال بالذات for choosing this topic. So this is the value of other targets in HER2 positive. So HER2 positive has been covered beautifully by Professor Azza. So I'll take some of what she said here. These are my disclosures. And we all know HER2 is overexpressed all over the body. This is physiologically present. So we have HER2 all over our body. So, but then with breast cancer, we do have an overexpression of HER2. And then if you have listened recently, there is the HER2 mutation and the co-mutations. So we're having subgroups coming. So ربنا يكون في عون اللي داخل الامتحانات الفترة الجاية. So, and we all know that the prognosis of HER2 is really bad because this from many trials before that with the amplification of more than 5 copies, you do have a worst disease-free survival and even overall survival. So to understand the mechanism of actually the HER2, so HER2 overexpression, it's a single, do I have the pointer here? Oh, okay, perfect. So it is a growth factor. So when it's mutated, it leads to downstream signaling of all these pathways, leading to proliferation, metastasis of the cancer cell. However, they found out there is something called the heterodimerization. Heterodimerization is binding of the half of the HER2 to another HER2 receptor, leading to heterodimerization. Hence, now we have the pertuzumab in the added on of the treatment or the arsenal of the management of the HER2. But hold your horses, because previously we had the NRG and we did not know what to do with that. So we saw the NRG mutation. What does it do? It actually overstimulates the heterodimerization. So if you have overexpression of NRG, then you don't need the heterodimerization of the receptor. It goes directly and stimulates the receptor. These are the HER2 FDA approved drugs for now that we do have in the pipeline. But then again, this shows you these are all the available drugs that we are using in the HER2. And if you look here, you will find that the cetuximab is there and the panitumumab, or in the epidermal growth factor receptors. There are some trials there. However, if you look here down there with the yellow stars, you will find that the pipeline is full of drugs. And I will touch that. Let's start with the bispecific antibodies. The zanidatamab. Zanidatamab is a bispecific antibody that structurally looks like the trastuzumab and pertuzumab. So it's a one drug, a bispecific antibody that binds actually to the HER2 and prevents the HER2 overexpression and the heterodimerization. Is it successful? Actually, we are waiting for that because we have an ongoing clinical trial, the zanidatamab, in advanced HER2 expressing cancer. So unfortunately, when I'm going through my slides, you will find that all are coming in the pipelines. We don't have any solid ground till now. What about the zanidatamab plus palbociclib, which touch bases like what Professor Azza showed us with the anti-HER2 and palbociclib? They're actually looking at the bispecific antibody and palbociclib in HER2 positive with hormone receptor positive. And last update post was on the 1st of August this year, and still no data available. This to explain something called the don't eat me signal. What is the don't eat me signal? So when you find the CD47 binding to the SIRP alpha, the orange ones, you'll find that this is a stop signal, which tells the immune system, don't eat me. It's called the don't eat me signal. So if theoretically we have a monoclonal antibody targeting the anti-CD47, then we can stop this don't eat me signal, leading to control over the tumor. Do we have anything regarding that? Yes, actually, with the bispecific antibody, the zanidatamab with evorpacept, which is an anti-CD47 don't eat me signal. Do we have data? Still in the pipeline. Then, remember when I told you about the NRG mutation, the NRG1? Now we have the zenocutuzumab, which is, again, a bispecific oral anti-NRG1. If you look here, the NRG1, remember when I told you, sorry, go back. So the NRG1, you have the NRG overexpression. When it binds to the NRG fusion gene, it stimulates the HER3 and the HER2. So if we theoretically block the NRG1 with the zenocutuzumab, which actually now has an FDA approval in usage, but in lung for now, it does actually work. And if you look here at the tumor agnostic trial, from the which was published actually this year in the New England Journal of Medicine, including all those cancers with the NRG1 overexpression, you will see that the waterfall plot curve, that there is a marked decrease in the size of the cancer present. But if you look at the breast, you will find the breast has a better response. So we were happy with the bispecific antibody. Let's look at the trispecific antibodies. عشان كده بقول لكم اللي دخل الامتحان ربنا يكون في عونه. Trispecific antibodies, now you have anti-Her2. So it's a trispecific. Tri means three. So it's an antibody that binds to the Her2 and then to the CD3 on the T cell and the FC receptor on the natural killer cells. So we improve the antibody directed cell cytotoxicity by including more of the natural killer cells with the T cells. Also, what about the ADCs? So ADCs have been, I'm not going to talk about what's known by the ADCs or the TDXD, for example, but don't forget, antibody drug conjugates are actually chemotherapy in disguise. It's like a Trojan horse. So if you look at the trastuzumab deocarmazine, so for those who attended the ESMO, the trastuzumab deocarmazine is booming right now. So what's the difference between the trastuzumab deruxtecan and the deocarmazine? It's only the added or the payload that is present. And this shows you the natural mechanism of the trastuzumab deocarmazine or the ADCs. They go inside and we have the bystander effect. Do we have trials for that? We do have the TULIP trial looking at trastuzumab deocarmazine and physician choice. And these are in patients with HER2 positive with more than or equal to prior lines. And as you can see here, the hazard ratio at 0.64 with a progression-free survival of almost 3 months. So as overall survival, you do have still a numerically different overall survival or a better overall survival. And this is numerically, not statistically, but maybe at a longer follow-up, or if we change the add-on arm, we can find a better outcome. So this shows you what do we have now. Anti-HER2 drugs strategies, we have the trastuzumab deruxtecan, the deocarmazine ongoing in the pipeline, the tucatinib, neratinib, pazopanib, and pyrotinib, and the bispecific antibodies. And then we do have the immune checkpoint inhibitors. And if you look here, you will find these are again ongoing trials because all the data are coming in the future. We don't have something right now. But if you look here, the TULIP, I said, the patina, the palbociclib with trastuzumab, as mentioned by Professor Azza, and then the NRG with the atezolizumab. So we are including the immune checkpoint inhibitors to the anti-HER2. And then you have the alpelisib, and which is known as the PI3K kinase inhibitor. Yes, we all know it's a very bad drug with side effects, but it's there because the PI3K pathway is affected. Professor Azza told us that the estrogen receptor or the hormone receptor pathways are intermingling with the HER2, and even the HER2 has other intermingling pathways as the APT, the AKT, and the PI3K. And you do have the bispecific antibodies with immune checkpoint inhibitor in the future. So to conclude my talk, the HER2 is a heterogeneous disease. So we all know that because from the HER2 low, the ultra low, and the HER2 positive, bispecific and trispecific antibodies are the futures because these are how we improve the immune system attacking the cancer cells, targeting the other pathways like the PI3K, the mTOR, and the addition of CDK4/6 inhibitors and immune checkpoint inhibitors might play a role in the add-ons in the future. And thank you so much for listening.
My honor to introduce my young sister, Dr. Iman Ali, medical consultant medical oncology at Baheya Hospitals, also consultant medical oncology at insurance hospitals. Here talk about brain metastasis of HER2 positive breast cancer, screening, prevention, and management.
مساء الخير. My talk about the brain metastasis of HER2 positive metastatic breast cancer patient, about screening and prevention and management. Overexpression of HER2 was seen in 15 to 30% of all breast cancer patients. However, about more than 50% of our patients with metastatic HER2 positive breast cancer patient will develop brain metastasis during their disease course. The presence of the brain metastasis are significantly affect the general condition of the patient and the carrying poor prognosis. We have many factors that associated with early detection of the brain metastasis in HER2 positive metastatic breast cancer, the high grade, de novo metastatic, the use of trastuzumab in 2 or more lines, those patients at higher risk of developing of brain metastasis. Another, we have the risk factor for poor survival in patients with brain metastasis is the older age, the poor performance status, the number of the multiple brain metastases, anterior fossa metastasis, the presence of neurological sign and symptom, and the number of the previous treatment. If we look to the NCCN guideline, well, we found there is a long list of medication that showing CNS activity in brain metastasis in HER2 positive breast cancer patient. In 2025, we have 2 major drugs with significant CNS activity with overall and BFS benefit. The first one is TDXD. The second one is the triplet tucatinib trastuzumab capecitabine. If we look now in 2025, the standard of care first line, the second line treatment in metastatic HER2 positive is TDXD. What about the CNS activity of the TDXD? The efficacy of TDXD in CNS disease came from 2 main publications. The first one, as we show here, it is pooled analysis collected from 3 different DESTINY trials, DESTINY 01, 2, 3, including about 148 patients. In this retrospective data, the median number of the previous anti-HER2 treatment was 3 lines, which represented heavily pretreated patients. Those patients was divided into active and stable brain metastasis according to the previous received of local radiotherapy. As we see here, the wide separation of the curve, those patients, the use of TDXD in the patient with brain metastasis showing statistical significant improvement of CNS, BFS, and overall survival, and the benefit was maintained regardless the patient was received radiotherapy or not. The intracranial objective response rate for TDXD, it was exceeding 45%. However, the intracranial duration of response was exceeding 1 year. The limitation of this study, it is retrospective data. We are collect the patient from 3 different clinical trials with different inclusion and exclusion criteria. The second important publication is the DESTINY 012. The DESTINY 012 is a single arm open label prospective study was conducted mainly to assess the efficacy and the safety of TDXD in the safety and efficacy of TDXD. Some consider this trial as real world data rather than prospective randomized trial. This trial was including patient with brain metastasis and the patient without brain metastasis. We'll talk about the patient with brain metastasis. The patient with brain metastasis here, we have including patient with stable and the active brain metastasis. What is the meaning of stable? Stable, the patient had previously received local radiotherapy or surgery, and at the time of the recruitment, the brain metastasis was stable. Like in patient with active brain metastasis, including 2 types of patients. The first one, the patient who had progressive brain metastasis after local regional treatment to the brain metastasis at the time of the inclusion, and was included as well the untreated brain metastasis. Untreated means the patient who had newly diagnosed brain metastasis, asymptomatic with no evidence of mass effect. The median number of previous anti-HER2 treatment of this DESTINY 012, 50% of the study had only 1 line of anti-HER2, so presented less heavily pretreated than the previous retrospective data. As we see here, the 12-month CNS BFS benefit was 58%. Please remember, it was single-arm prospective study. However, the objective response rate was 51%. The patient with measurable brain metastasis, the objective response rate for CNS metastasis, it was 70%. The overall survival data is still mature. What about the untreated brain metastasis? The patient who had presented by asymptomatic brain metastasis, and we offer for them TDXD, and we postpone the local regional radiotherapy. The CNS objective response rate was 82%. However, the patient with progressive brain metastasis, those patients, when we give the TDXD, the CNS objective response rate was 50%. What about the second player or the old player, the triplet tucatinib trastuzumab capecitabine? The efficacy of this triplet was proved by Her2 claim study, as mentioned by Professor Azza. It was randomized phase 3 study comparing between triplet trastuzumab capecitabine Xeloda versus doublet trastuzumab capecitabine, showing there is statistically significant improvement of BFS and overall survival. This study, 48% of the study population had a brain metastasis, about 290 patients. However, the median number of the previous anti-HER2 treatment was 3 lines. Again, it was heavily pre-treated patient. But what about the CNS efficacy of this triplet? As we see here, the beautiful wide separation of the curve, there is statistically significant improvement of BFS and overall survival. Again, the benefit was maintained either in the patient with active or stable brain metastasis, with doubling of intracranial objective response rate, 47 versus 20%. By the way, the Her2 clamp study was the first randomized large trial that allowed to include the patient with active brain metastasis. However, Destiny 01, 2, 3, none of this trial was allowed to include the patient with active brain metastasis. For knowledge, the Cleopatra study, any patient with brain metastasis was not allowed to be included. However, still this is the standard of care first line treatment. طيب, into the Her2 clamp study, we have two observations. The Her2 clamp study was the same like the Destiny 012. It was included patient with untreated brain metastasis, asymptomatic, newly diagnosed patient. Those patients, the intracranial objective response rate was about 47%, which is double, and with statistical significant improvement of CNS, BFS, and overall survival. Some of those patients, about 30 patients, who presented with isolated CNS progression without evidence of systemic progression, those patients we are continue the tucatinib trastuzumab capecitabine. Again, this patient who continue beyond the progression have statistical significant improvement of BFS2 with hazard ratio 0.29. Now we have two players. The new player is the TDXD, and the old one is the trastuzumab tucatinib triplet tucatinib trastuzumab capecitabine. By the way, after the result of Her2 clamp study, the ASCO guideline for brain metastasis in 2022 with a change her statement, and they recommend, yes, if you have a patient with single or multiple brain metastasis, asymptomatic or mild asymptomatic with no evidence of mass effect, for those patients, yes, you can offer for them triplet tucatinib capecitabine Xeloda, and you can postpone the local radiotherapy for further progression. Into 2025, now we have the standard of care second line treatment in metastatic HER2 positive is TDXD, regardless the presence of the brain metastasis and a brain metastasis. Now we have the agent showing efficacy in CNS metastasis with objective response rate exceeding 5%, and showing efficacy as well in the patient who presented with asymptomatic brain metastasis, and we can postpone radiotherapy for those patients. Type. I give the TDXD as a standard of care second line. What to give beyond TDXD progression? Some fact. First of all, we don't have any consensus. We don't have a consensus to tell us what is the best treatment option beyond TDXD. It is one of the unmet clinical need. There is no available clinical trial to tell us again what is the best treatment sequence. None of the trial, including TDM1, lapatinib, neratinib, was including patient with TDXD. Even if we search in the literature for real world data, it will be very sufficient, very deficient. We found some data, including small number of patients, single institution trial, again cannot tell us what is the best treatment option beyond TDXD progression. However, now the expert all over the ESMO, ASCO, they prefer to give the TDXD as a standard of care second line, regardless the brain metastasis. And they push that the triplet tucatinib capecitabine trastuzumab to be the preferred second line beyond TDXD progression. Again, regardless the brain metastasis. Why? They feel that it is the experts are not feel comfortable to give antibody drug conjugate beyond antibody drug conjugate progression. They doesn't feel comfortable to give TDM1 post TDXD, and it's better to give TKI like tucatinib trastuzumab capecitabine post TDXD progression. If the patients progress into tucatinib, they push the TDM1 to be the fourth line. Again, after now we have two major drugs, TDXD and tucatinib. After these two drugs, as we see here, we have a very long list of medication. TDM1, neratinib combination, Xeloda, Tykerb. However, Again, we don't have a clear guideline to tell us what the best treatment sequence of anti-HER2 treatment. طب TDM1, again as mentioned by Professor Azza, the TDM1 was proved as a second line treatment according to Emilia study with improvement, with statistical significant improvement of BFS and overall survival. طب what about the CNS activity of TDM1? CNS activity of TDM1 is coming from Camellia study. الكاميليا study, it was a single arm prospective study was conducted to assess the efficacy and the safety of TDM1, including patient with brain metastasis and the patient without brain metastasis. It was including 2,000 patients. About هنا 400 patients had a baseline brain metastasis. As we see here هنا, again, the Camellia study was including only patients with stable brain metastasis. The active brain metastasis was not allowed to be included. The objective response rate was 21% and the median BFS about 6 months with median overall survival 19 months. And about more than 40% of the patient had more than 30% reduction in the sum of the largest diameter of the target brain lesion. And the patient, there is some of patient, about 67 patients who had presented with isolated brain metastasis without evidence of systemic progression. Those patients, we continue the TDM1 beyond the progression. Again, with maintain the median BFS benefit هنا was touching 9 months. طيب, the study, this study, the limitation of the Camellia study is it is single arm prospective study, not comparative study. So the making the expert or making the guideline cannot put clear indication or clear guideline about the efficacy of TDM1 in the brain metastasis. But definitely we have a drug that's showing CNS efficacy. طيب, what about the neratinib combination? The neratinib capecitabine efficacy was proved in the NELA study, which is randomized phase 3 trial comparing between neratinib capecitabine versus labatinib capecitabine in the patient who received at least 2 previous line of anti-HER2 treatment. The primary endpoint was BFS and overall survival, and the secondary endpoint is the time to intervention to the brain metastasis. More than 70% of the study population had received at least 2 lines. Again, it is heavily pretreated patient. As we see here, there is statistical significant improvement of BFS. However, the overall survival benefit was no statistical significant. طيب. طب what about the CNS activity بتاعت combination of neratinib capecitabine? As we see here هنا, there is only numerical improvement of all CNS endpoint هنا, progressive CNS BFS, CNS objective response rate. But here I will stress on 2 points. The first one is the 12 months cumulative incidence of intervention to CNS disease. It was 25 versus 26. What is the mean? The neratinib, it was the first anti-HER2 drug that was prescribed to decrease or to prevent or to delay the development of the brain metastasis in HER2 positive metastatic breast cancer patient. The second observation is the duration of the response. Duration of response is about 9 months. We are talking about the drug who is used in patients who received at least 2 lines with duration of response 9 months. طيب, another important question. What is the efficacy of neratinib combination in patients who received previous TDM1 in the adjuvant or metastatic setting? The patient who received labatinib capecitabine, now we have a drug is approved in patients who received at least 2 lines of previous anti-HER2 treatment. For that, we have this phase 2 study. Phase 2 study, it was phase 2 study, prospective single-arm study, divided into 4 cohorts. I will talk about cohort 4 and cohort 3. Cohort 4, it was included patient with measurable brain metastasis, where the patient was received neratinib 160 plus TDM1. Neratinib هنا used in 160, not the standard dose 240 to avoid the toxicity. The primary endpoint was the CNS objective response rate. The patient in this cohort was assigned to 3 arms. The first arm, the patient with stable brain metastasis. Second arm, the patient with active progressive brain metastasis did not receive TDM1 before. And the third arm was the patient with progressive brain metastasis with previous received TDM1. As we see here, the objective response rate with the patient with stable brain metastasis 50%. The patient with progressive and did not receive TDM1, the objective response rate was about 30%. However, the patient with progressive brain metastasis and previously received TDM1 either in metastatic or the adjuvant setting, the objective response rate was 23%. Now, yes, this protocol, to be honest, is not included yet in the NCCN guideline. However, many experts, they feel that this combination of neratinib of TDM1 can give us as a solution in the patient who had received TDM1 before in the adjuvant or metastatic setting. What about the cohort 3? Cohort 3 was included only patient with measurable progressive brain metastasis, giving the patient neratinib, capecitabine. The primary endpoint was CNS objective response rate. The patient was assigned to 2 arms. First arm, the patient who did not receive TICAR, the objective response rate was 48%. And the second arm, the patient who had previously received TICAR, the objective response rate was 33%. The last. What about the screening and the prevention of the brain metastasis? What I talked before, I talked about what is called the secondary prevention. The medications that can delay or can postpone the progression of already patient who's diagnosed with brain metastasis. What about the primary prevention? Do we have a primary prevention? Unfortunately, all the drugs that used in the adjuvant, neoadjuvant setting, trastuzumab, pertuzumab, lapatinib, neratinib, TDM1, none of those drugs was proved to have not proved to have she can decrease or reduce the risk of the brain metastasis, except the neratinib. Neratinib was used in the adjuvant setting for the patient who had lymph node positive, hormone receptor positive. Those patients, yes, have decreased the incidence of the development of the brain metastasis. What about the screening? Do we need to screen those patients with metastatic HER2 positive breast cancer patient? Yes, we need to screen this patient. Why? Now we have a disease with more than 50% of the population will develop brain metastasis at a certain point of their disease. Second one, if we can screen this patient, we can catch up the brain metastasis very small. طب ايه المشكلة انا امسكها very small؟ هتديني مستين. اول حاجة نقدر we can treat this patient by stereotactic radiotherapy. When you treat the patient with stereotactic radiotherapy for small brain lesion, you decrease what is called the radiation necrosis. Radiation necrosis is one of the things which is very difficult for diagnosis and difficult for the treatment. The second one, if you can catch the brain metastasis in a small size definite you can use the antibody drug conjugate like the TDXD and the tucatinib, and you can postpone the radiation therapy to further progression. What about the international guideline? None of the international guideline ASCO on ESMO, they recommend, none of them, they can recommend for routine screening for brain metastasis. The ASCO guideline justifies that there is insufficient data to recommend for or against the performing routine surveillance. However, the NCCN guideline recommends the physician to be very low threshold to perform the MRI for any patient who presented with any signs of CNS disease. Last slide. What about the ESMO? There is expert consensus for prevention of brain metastasis in patients with HER2 positive breast cancer was done in 2024, however, the result was published in this year. Again, this consensus are again refused to recommend the routine screening for CNS metastasis. However, 70.6 of the panel, they are approved for, or they are insisting to do screening for the patient of high risk patient, HER2 positive metastatic breast cancer patient, to screen the patient for brain metastasis in the absence of any neurological symptom. Yes, definitely. There are many experts all over the world, they recommend to do screening, but international guideline does not recommend for the absence or for decrease or there is insufficient data about the screening. Thank you.
Thank you, Dr. Aman, for the excellent presentation. Any question?
I have comment and I have objection. The comment is for, you mentioned first and second line in patients with metastatic brain mets, and you never mentioned the role of radiotherapy on progression. Because if you have progressive brain mets, of course you will have increase in size and maybe the risk of hemorrhage, and when to interfere with radiotherapy.
Yes. أول حاجة لو أنا عندي عيانة metastatic HER2 positive breast cancer patient, she was maintained of anti-HER2 treatment like Cleopatra protocol for long time, and this patient was presented only with isolated brain recurrence with controlled systemic treatment. The guideline tell us those patients should be treated only by local radiotherapy, SBRT, or surgery according to the tumor size and the presence of mass effect. And we continue on the same anti-HER2 treatment for the patient who had isolated CNS recurrence with controlled systemic treatment.
No, and I don't ask about when to use the give radiotherapy on progression. When
On
you
progression.
give already.
Yes, yes. If I have a patient with metastatic breast cancer to the brain and she was maintained on systemic treatment, we will look this patient have only isolated brain progression ولا عندها مع الايزوليتد brain progression في systemic progression. لو العيان عندها isolated brain progression and we have access to TDXD أو triplet to catanib trastuzumab capecitabine, yes, the guideline tell us go for this systemic treatment provided إن العيانة يبقى التيومر سايز بتاعها أقل من 2 سنتي وإن ما يكونش عندها ماس إفكت أو تكون سيمتوماتيك أو مايل سيمتوماتيك أو السيمتوم ويل كنترولد أون ستيرويد. لكن لو العيانة عندها multiple يعني في evidence of systemic relapse برضو we can go for systemic treatment. Some of patient بيبقى عندهم evidence only of CNS progression بس CNS progression ده عامل symptom ساعتها أفكر أعملها re-irradiation زي أن أنا أعمل لها further SRS نعمل لها نديها لو كانت واخدة SBRT أديها whole brain.
So you still believe in the role of radiotherapy?
Yes. The indication,
This is my point.
الانديكيشن اللي حطوها علشان نبوستبون الراديشن ثيرابي ونكتفي بالراديوثيرابي very restricted. التيومر سايز يبقى اقل من 2 سم، العيانه تبقى symptomatic or mild symptoms ويكون availability of effective anti-HER2 treatment.
That's why I'm asking on progression.
Yes.
So there is main role of radiotherapy on progression.
Definitely.
The second point, but it's objection about the radiation induced necrosis. يعني actually we are seeing this very rare, minimal with such advanced radiotherapy and all. So يعني not to make it a big sentence because
هو ممكن يكون الكونسيرن دلوقتي على الراديشن نيكروزس ان هم دلوقتي عايزينها يدينا SRC لاب تو 10 or 20 lesion in the brain. وكل ما بنزود الاس ار سي وكل ما بنزود الدوز وبنزود الفوليوم كل ما بتبقى العيانه ات ريسك اوف راديشن نيكروز. هم جاست بيجاستيفاي احنا ليه عايزين نعمل سكريننج للعيانين دولت عشان تو كاتش اب ان سمولر ريجن.
So very good. Thank you very much.
Thank you.
May I add another point, please, for Dr. Azza. Dr. Azza. Professor Dr. Azza, thank you for your excellent presentation. And just I have 2 comments. The first one you mentioned in your presentation, the sequencing of treatment in advanced HER2 positive disease. And I don't know if the message or the scenario of treatment you give us is applied for locally advanced and metastatic or metastatic only. This point was not clear in your presentation. It applied for both, locally advanced and, okay. So the second point, you know that patient with HER2 positive breast cancer, if you give first line and second line and third line, they will develop resistance. So after the third line you mentioned in your scenario of treatment, so what we will do?
After the patient exhausted all the lines, trastuzumab, pertuzumab, TDM1, TDXD, طبعا TDXD, even remember the first earlier trials of TDXD in the Destiny 01, they recruited patients who are heavily pretreated, progressed in several lines of chemotherapy and trastuzumab and pertuzumab. Yet the PFS in this trial was almost 16 months, equivalent to the PFS seen in the Cleopatra trial. TDXD actually is the magic drug that can be given even in later line for patients who are heavily pretreated. The question is, if the patient already treated with TDXD, what are the options that we have? As I mentioned, naratinib, penjoximab, trastuzumab, again, plus chemotherapy single agent. If it is triple positive, I have to consider the hormonal treatment. But definitely, as progression occurs, the PFS will be shorter and shorter with every progression. But as Dr. Ahmed showed in his presentation, there are newer agents and newer combination, newer targets in patients with HER2-positive advanced breast cancer. Yes, of course. Thank you.
Thank you. We will move to next session. I am pressured to introduce daily colleague Dr. Mustafa Saidi, consultant of medical incursion in Baheya Hospital and Maadi Meralty Hospital. He will talk about his presentation about metastatic breast cancer, HER2 positive patient.
And thanks for Prof. Amani Hilal to give me the chance to be here today. This case is 56-year-old female, married, and has one offspring. She is hypertensive. She has a positive family history of breast cancer. Initially diagnosed as left breast invasive duct carcinoma grade 2 on 23 of March 2021, was clinically T2N2, ER positive, BR positive, and HER2 negative. Breast sonography at the time revealed a regular speculated dense mass lesion is seen in the upper outer quadrant of the left breast, about 2.4 and 2.7 centimeter, with multiple enlarged left axillary lymph nodes. The largest was 4 and 2.5 centimeter. Disfortunately, the patient lost follow-up and neglected her condition for about 2 years and came back to Baheya in 22 of July 2023 with rapid progression, with the whole breast replaced by the malignant mass with skin ulceration and edema. Breast sonography revealed left upper outer quadrant ulcerated mass associated with diffuse skin thickening and harboring group of amorphous microcalcification with left fixed amalgamated left axillary level 1 and 2 lymph nodes. CT chest and pelvis with contrast at the time revealed marked progression of the left breast mass, about 9.2 centimeter compared with 2.4 and 2.7 centimeter, seen infiltrating the overlying skin and underlying pectoralis muscle, with marked progression of the left axillary lymph nodes, about 6.7 and 9.7 centimeter. With progression of the previously seen number and size, small pulmonary and pleural-based pulmonary nodules, largest 2.3 and 2.9 centimeter. As we see here, the breast mass and pulmonary nodules with marked progression as 2 years of neglected and untreated patients with newly developed bone metastasis. The next step, what's the next step for management? Here, if we can go with the first biopsy or to take another biopsy. Thanks for Prof. Hanan Ramadan, as she asked for another biopsy, which revealed mucinous carcinoma grade 2, cellular variant, ER positive, strong, and PR positive, and HER2 positive score 3. So we have a patient with metastatic breast cancer hormone positive and HER2 positive. As we know, the percentage of HER2 positive breast cancer about 15 to 20%, hormone positive HER2 positive about 10%, and hormone negative HER2 positive about 4%. With the advent of and discovery of HER2 oncogenic driver in 1980s, and there is evolution in the treatment of HER2 positive breast cancer with multiple discovered line of treatment until TDXD, which many trials started from Destiny Breast 01 until I think it will be open for forever for this line of treatment. In our case, metastatic breast cancer, and according to Cleopatra trial, the survival with pertuzumab, trastuzumab, and docetaxel as a first-line therapy, there is a difference in overall survival, 57.1 months with THB versus placebo and HD. And also for progression-free survival, there is a difference. It was 18.7 months versus 12.4 months. So patient received the first line THB for 6 cycles and ended treatment on 20 of January 2024. The evaluation by CT chest abdomen with contrast in comparison with previous show regressive course of the left breast mass and left axillary and mediastinal lymphadenopathy, and regression of the bilateral pleural pulmonary metastatic deposits, sclerotic transformation of the previously noted D12 mixed lytic and sclerotic deposits. As we see here, the difference from this is before treatment with THB and this is after. Regression of the pleural based and pulmonary deposits and regression of the breast mass. Then the patient continued on AI and HB till July 2024. When during the evaluation with PET-CT revealed suspected brain metastasis, so we patient performed MRI brain, which revealed left inferior temporal and left superior parietal 2 intra-axillary space occupying lesions, likely metastatic, with surrounding visogenic edema and mass effect. And the patient received palliative radiotherapy to the brain at this time. Then we search for the second line for metastatic HER2 positive breast cancer. According to Emilia and Teresa trial, the TDM1 was approved as a second line for HER2 positive metastatic breast cancer after progression on HER2 target agents. But with Destiny Breast 03, TDXD throughout the TDM1 from the second line to the third line. This study, as mentioned by previous talkers, was a multi-center open label phase 3 study. The patients with unresectable or metastatic HER2 positive breast cancer, previously trastuzumab plus taxane in metastatic setting or neoadjuvant with recurrence less than or equal 6 months of treatment. The primary endpoint was progression-free survival. Okay, second point, overall survival. As we see, there is large space between the DDXD and TDM1 regarding the progression-free survival. About 28.8 months versus 6.8 months for TDM1. Also for overall survival, there is a difference. The trial is not reached for both regarding overall survival for TDXD and TDM1. Regarding the characteristic difference between TDXD and TDM1, the payload mechanism of action with TDXD topoisomerase 1 inhibitor and TDM1 antimicrotubule. The drug to antibody ratio is 8:1 in TDXD and 3.5:1 in TDM1. The tumor selective cleavable linker is present with TDXD. Evidence of bystander anti-tumor effect present with TDXD. So the patient started the second line TDXD on 5th of August 2024, and she received 17 cycles. The last cycle was on 11th of October 2025, and she is well tolerated to the treatment. Evaluation during the course of the treatment with TDXD shows PET-CT on 23 of January 2025. Size and metabolic regression of the left breast neoplastic lesions and regression of the left axillary lesions. Also regression and metabolic remission of the left supraclav lymph nodes and the non-appreciated left temporal lobe metabolically inactive space occupying lesion, and regression of multiple avid mediastinal lymph nodes, and regression and metabolic remission of the previously needed bilateral parenchymal and pleural based lung nodules. This is before TDXD treatment, and this is after 5 months of TDXD treatment. This is MRI brain in the last 31 of This is MRI brain was compared with the previous study, revealed resolution of the previously noted left temporal and parietal 2 intraaxial space occupying lesions, as well as the surrounding pathogenic edema and the related mass effect. As we see, there is marvelous response in the TDXD treatment. I will speak concisely about the management of common TDXD-related adverse events. The most common in Destiny Breast 03, any grade and grade 3 nausea occurred in 72.8% and 6.6% of patients respectively. Vomiting with any grade experienced in 44% and grade 3 in 1.6 patients. So it's important to give prophylactic antiemetic treatment with the first cycle of TDXD. In patients without specific risk factors for emesis, the pre-medication regimen during the first cycle should initially consist of 2 drugs, dexamethasone and 5-HT3 receptor antagonists. This is according to the last ESMO recommendation, and consider the use of a 3-drug prophylaxis for high-risk patients, like those with history of emesis with other treatments, or for frail patients. The 3 drugs, NK1 receptor antagonist, 5-HT3 receptor antagonist, and dexamethasone. In patients who experience nausea or vomiting despite the 3-drug regimen should be offered for addition to olanzapine. If grade 3 nausea and vomiting, we should delay dose until resolved to grade 1. If resolved in 7 days, maintain the dose. If resolved in more than 7 days, reduce dose 1 level. The second most common and serious side effect for TDXD is interstitial lung disease. It is characterized by ineffective gas exchange due to alveolitis, disrupted alveolar structure, and fibrosis. As we see here, the percentage in Destiny Breast 03, about 15.2%, all grade interstitial lung disease. So it's a serious side effect, and we should have attention to it. There is a specific mechanism with antibody drug conjugates. Series include target-independent uptake of the payload in immune cells, bystander effect of released payload, and damage from circulating payload after release. So early diagnosis and intervention are important to avoid this serious outcome. First, to monitor the patient, urge the patients to immediately report any symptoms and signs of interstitial lung disease. Then we should assess the patient with high-resolution CT and the pulmonologist consult if indicated. Interstitial lung disease consult. Infectious disease consult. Then blood culture and CBC and other blood tests. As needed. Consider bronchoscopy and bronchoalveolar lavage if indicated and visible, and other examinations. If grade 1 interstitial lung disease, we should hold until resolved to grade 0. Consider corticosteroid 0.5 milligram per kg per day, prednisolone. Then if resolved less than 4 weeks from onset of interstitial lung disease symptoms, maintain the same dose. And if resolved more than 4 weeks after the onset, reduce dose 1 level. In case of grade 2 to 4, should permanently discontinue the treatment with TDXD. So we should follow the 5S rules, which is screen and scan, synergy, suspend treatment, and steroids. Thank you.
Should we open the discussion, please, Dr. Amani? Okay. So, Professor Dr. Heba, تفضلي. We know that we are beyond the time, but
ألف شكر يا دكتور، كتر خيرك. الحالة كانت بصراحة ممتعة، من الحالات البروبلماتيك. يعني we have to think many times، وطبعا عارفة إن في ناس consultant يعني أفاضل، الدكتوره اماني وحبيبتي وفوق راسي الاستاذه الدكتوره حنان رمضان قدها وقدود. انا بس
تمام.
عايزه اعلق عشان everybody is here. طبعا كونها ان هي غابت ونجلكتد وجت، طبعا this is normal and must be for all of us a routine and to do rebiopsy.
Yes.
ولما rebiopsy you change the decision of treatment and this is الواقع. استنى حضرتك ثانيه عشان اكلم البانل. فطبعا ده نورمال، واحيي الدكتوره حنان، بس لازم يبقى لينا كلنا. وكمان الدكتوره ناديه مختار قالت ان 15% بيحصل تشينج within 2 years، فكل الكلام ماشي مع بعض. الحاجه اللي عايزه الفت نظر حضراتكم جميعا ليها، العيانه دي metastatic with 2 sites of metastasis pulmonary and bone، وشي have 6 cycle of treatment. خليك معايا للاخر. with regression of some site of metastasis but not complete remission.
Yes.
هنا في النقطة دي معلش my message is until disease until complete أو maximum response أو toxicity. معلش
Yes.
يا جماعة، أنا دايما كل يوم إحنا بنابلاي الادجوفنت بوليسي على الميتاستاتيك. this is not يعني أنا مش هكون زعلانة منك لو كملت ال10 بس مفيش توكسيسيتي.
بالظبط.
حكاية إنك قلبت على هرمونال أهلا وسهلا وممتازة، بس مش مفروض في الحتة دي. ده تاني مش كانش هيأخر البرين ميتاستاسيس. brain metastasis it will appear، بس while you have a patient with 2 sites of visceral metastasis أو bone وvisceral وبرين، البرايس بتاعها عالي جدا to cure أو to complete remission. فهمت قصدي؟
Yes.
يعني انت اشتغلت حلو جدا في البرين واشتغلت حلو جدا في الأول. أنا my concern is why not to continue the same treatment and then give some hormonal treatment.
Yes. Continue taxotere until.
الحاجة اللي استفادت منها.
Yes.
PHB.
until maximum response.
انت قلت regression
Yes.
فهقلبها على هرمونال. على فكرة كلنا ساعات بنعمل كده، بس لما العيانة تقول I cannot tolerate more treatment.
Yes.
أنا I notice إن هي 40 something فشي is tolerating the drug.
Okay. Yes.
Double comment.
Thank you very much, Professor Dr. Heba, for this point. You have any يعني reply for this point for Dr. Heba?
Yes.
Is the patient developed toxicity during the treatment? That's why you shifted here for hormonal?
Yes, the patient developed peripheral neuritis, so shifted to AI.
So there was a
Yes.
reason for
Yes.
treatment switch. Well, maybe. Any other question, please?
كومنت دكتور هبه على الكيسز، يعني ايجيبشن كيسز بالذات البريست كانسر او وات ايفر الكانسر بيشنت في ايجيبشن في انذر كوموربيديتي، ممكن تكون دايابيتيك اوريدي عندها بريفرال من الدايابيتس، يعني all patient or most of the patient cannot tolerate it more than 18 or 24 taxol weekly. فايفن I will reduce the dose ل 60 ملغ per meter square. Still the patient complaining. For while patient cannot tolerate the taxol يعني more than this weeks. We found another option again. We have ERPR positive. We can shift to hormonal treatment with Her2 and pertuzumab. والبرين ميثود as you told will be appear. يعني cannot also there is many toxicity in taxol at this times. Epistaxis, allergy of no reason like hand, like face. This is also problems facing with our patients. Sometimes we stop according to the allergy, epistaxis, peripheral neuritis, the common with our patient because many comorbidity, diabetes or hypertension.
I have the feeling that this patient يعني you worked with her systematically. And
Yes.
only this point for Professor Dr. Heba is the the valid point that
Okay.
why you shifted the patient while she has progressive response. I mean, not progression of the disease. The second point you mentioned is for this patient that she was hypertensive in the beginning.
Yes.
Is this has any relation with your treatment or concerned point for you during the treatment? Because
Yes.
you didn't mention after that this
Yes,
hypertension.
yes, we should follow with echo every 3 months during the treatment, and if it accepted, we can continue the treatment. And the patient,
And it has high
yes.
risk of cardiac disease
Yes.
more than other patients.
Yes.
So this point we should put
We should,
eye on this. Okay.
Okay.
I think any more question for Dr. Any more question? Thank you very much. We are going to close these sessions. I would like to thank all the professors for your attendance and interactive discussion.